Morning everybody, and today what we're going to discuss is the management of type 1 diabetes. Now this is the first in our series of 5 lectures on diabetes totaling 10 hours. Just to give you an example of what exactly is going to go on, first we're going to discuss the management of type 1 diabetes, specifically looking at the use of insulin. Then we're going to look at the acute complications and the management of acute complications of diabetes. And then what we're going to do is we're going to look at the management of type 2 diabetes. And then we're going to look at microvascular complications of diabetes. And then we're going to look at cardiovascular disease and diabetes. In total, this will be a set of 10 hours. What I'm not going to cover is the diagnosis of diabetes because you've already done that in your STEPS lectures and you should already know that. Just as an aside, I will however expect you to know how to diagnose diabetes, so it's worth going through those lecture notes again as you prepare for this particular section and as you prepare going forward for your exams. Now there are two types of diabetes. There's type 1 and type 2 diabetes. Just remember that we use the Arabic Indian numeral 1, right? Not the Roman numeral 1, because type 1 diabetes is essentially about beta cell destruction and there is a complete lack of insulin, whereas in type 2 diabetes, remember that it is the Arabic numeral type 2 and not the Roman numeral type 2. There is more beta cell dysfunction and insulin resistance. Obviously there are more than just type 1 and type 2 diabetes, but for the purposes of these lectures we're mostly going to talk about type 1 and type 2 diabetes. There's of course latent autoimmune diabetes of adulthood, there's gestational diabetes, there's so many different kinds of diabetes, but just for the time being we're going to discuss these two. You'll note that type 1 diabetes commonly occurs in childhood and has a peak incidence at the age of puberty or late adolescence, but you can get it in people up till the age of about 30 years, and it's worth noting that even still, right, what happens is type 1 diabetes can occur at any age. Comparatively, if we were to compare type 1 to type 2 diabetes, type 1 diabetics are generally slimmer, they are younger, they tend to be symptomatic, meaning they have the signs and symptoms of diabetes such as polyuria, polydipsia, polyphagia, weight loss. They're insulopenic in that they don't have any insulin. Right, and remember that insulin acts as the key, so that what you can do is you can take up the glucose into your cells. So no insulin, no key allowing glucose to be taken up into your cells, your body will start to break down fat. By breaking down fat, you will produce a ketotic state, and therefore they are more ketone prone, and of course they don't have a family history of type 1 diabetes. Comparatively, by type 2 diabetes, generally there are people who are older, they tend to be overweight. Now, as you will realize, we now have a childhood obesity problem, and as a result of that, we're going to come to a point in time where we're going to have a lot of children who have type 2 diabetes, not type 1 diabetes. Generally, type 2 diabetics are often asymptomatic, they are resistant to insulin, and they don't generally suffer from ketosis as much, and there's generally a family history of type 2 diabetes. The classical symptoms of diabetes include polyuria, polydipsia, nocturia, polyphagia, or extreme hunger, and this is largely due to the fact of the presence of glucose in the urine, also known as the osmotic symptoms of hyperglycemia. Now, the osmotic symptoms of hyperglycemia means that you will urinate a large amount of glucose. Urinating a large amount of glucose will then in turn make you extremely hungry and extremely thirsty, and because that large amount of glucose is actually calories that you consistently urinate out, you will start to lose weight as well. It's worth noting that most commonly patients with severely high blood glucose levels will have the osmotic symptoms of hyperglycemia. So we're talking once they pass the renal threshold for glucose. In adults, it's roughly about 15 millimoles per liter, and in children, it's about 10 millimoles per liter or thereabout. Other non-specific symptoms, consistent infections, erectile dysfunction in men, blurred vision, tingling of the hands and feet, genitourinary infections is another example, vaginal infections is another example. Consistently getting these infections should raise a red flag in the practitioner's mind to suggest that the patient may have diabetes. Now, the Complications of diabetes are either large vessel complications or small vessel complications. The small vessel complications or microvascular complications include nephropathy, retinopathy, and neuropathy. And the large vessel complications usually are atherosclerotic in nature and include myocardial infarction, strokes, and peripheral artery disease. Peripheral artery disease combined with neuropathy together will give us a diabetic foot disease, which is something that we've already discussed in steps, and so we won't go into too much detail going forward. We will, however, discuss diabetic neuropathy in some detail in the microvascular complications lecture. So let us discuss the pharmacotherapy of insulin. Now, before I go on, I just want you to understand that insulin is the mainstay of therapy for type 1 diabetes. You're going to find a lot of people coming to you and telling you that, listen, type 1 diabetes is worse than type 2 diabetes. And that's not necessarily true. Simply taking insulin does not necessarily mean that a type of diabetes is worse than any other type of diabetes. Remember that in type 1 diabetes and towards the end of type 2 diabetes in particular, so once you've had type 2 diabetes for about 10 to 15 years, you no longer have enough insulin. And as a result of that, we have to start giving you insulin. Right? So what does insulin actually do? Well, insulin is responsible for glucose uptake into muscles and tissue. Right? It's also responsible for breaking down glycogen, for synthesizing glycogen, right? For protein synthesis, and for uptake of ions like potassium and phosphates, for example. It prevents ketogenesis because it ensures that your tissues take up glucose. It prevents lipolysis, right, which is the breakdown of fats to produce ketones, which will break down of fats to actually support your body, but in so doing will produce ketones. It stops glucogenolysis, which is the breakdown of glycogen, and it also stops gluconeogenesis, which is the making up of extra glucose molecules. Remember that gluconeogenesis requires you to break down fats, etc., etc. This is all stuff that you already should remember. Now, the classification of insulin is generally based on the type of insulin, the onset of action, the onset and duration of the peak, right? And of course, the total duration of action. So you have some insulins that are considered peakless, like glargine, Detamer, and degludec. Some that have peaks, like Lispro, Aspart, and glulicine, for example. And then also regular human insulin also has quite a substantial peak, and NPH insulin tends to have a substantial peak as well. You can see here that the peakless insulins that we do mention here are Detamer and glargine. There's also degludec, which will also be around here somewhere. So if we were to draw in degludec, it would look something like that, because it has a much longer action than even glargine and Detamer. Right. Rapidly acting insulin analogs. These include Lispro, Aspart, and glulicine. Short acting insulin is stuff like regular human insulin. And intermediate acting insulin is isophane insulin or NPH insulin, which is neutral protamine Hagedorn insulin and Lenti insulin. Long-acting insulin analogs are glargine, Detamer, and degludec. And then, of course, you have premixed insulins, which are generally a combination of a short-acting insulin, either combined with NPH or rapidly acting. Either combined with NPH, or alternatively, you have rapidly acting insulin with some kind of a long-acting insulin. So the rapidly acting insulin analogs include Lispro, Aspart, and glulicine. Now what tends to happen, if you see the onset of action, right, you'll see that Lispro's onset of action is 0 to 15 minutes, glucicine's is 0 to 15 minutes, Aspart's is 10 to 20 minutes. They peak generally between 1 and 3 hours, and they last for 3 to 5 hours. So ideally, right, What we're talking about here is the rapidly acting insulin analogs are mostly bolus components. In other words, they are mostly meant to be taken before a meal. And you can see that the onset of action will generally guide you. So roughly about 15 minutes to half an hour before the meal is when the person wants to inject their bolus insulin doses, right? Because that will then prevent their glucose spiking from spiking too high during their meal and 2 hours after their meal, because it will peak at roughly 1 hour and will continue to work for 3 to 5 hours. Now, glutathione provides consistent and predictable exposure with rapid early glucose disposal and has a short duration of action. It's not influenced in any way by the site of injection, and it provides mealtime flexibility. In other words, if you are not eating, right, you don't necessarily have to take it. And glutathione, right, as you'll see here, and as the mistake is clearly on the slide, is actually the bolus component of the basal bolus regimen. So just remember, it's the bolus component. And I'll try and fix this on the slide before I put it up. And glutathione is ideal for patients with type 1 or type 2 diabetes, ideal for adults, adolescents, and children more than 7 years, renally impaired patients because there's no need for dose adjustment, and ultimately it tends to be useful in patients with a wide-ranging BMI. Now, with mealtime flexibility of glutathione means that if you don't eat, you don't need to take it, and then you'll only take your glutathione the next time that you eat. That's what it allows for, which is something you don't get with other insulin analogs, generally speaking. Short-acting insulin or regular human insulin, right? Also, onset of action is 30 to 60 minutes. Its peak is within 2 to 4 hours, and it works for 6 to 8 hours. Remember that regular human insulin is the ideal insulin that we use when we want to treat patients with ketoacidosis. It's also the bolus component, and particularly in in the public sector, you will find that regular human insulin is generally used as the bolus component of the basal bolus insulin regimen. Intermediate acting insulins, like for example isophane insulin or NPH insulin. NPH insulin onset of action is 60 to 90 minutes, and its peak is 4 to 12 hours. Its duration of action is roughly about 18 hours, which means that it's used as the basal component of the basal bolus dosaging, right? It also means that depending on how much the person metabolizes and how much they use, you may need to, of course, use the NPH insulin twice in a day if you were using it as a basal insulin, as opposed to something like glargine or degludec, which you would only need to use probably once a day. It's a cloudy insulin, and the absorption is affected by the injection site, and therefore where there are slower injection site such as the buttocks, for example, you would therefore mean that you would have slower absorption of your NPH insulin. And of course it can be used for basal supplementation purposes as well. NPH insulin does not adequately mimic basal insulin profiles due to its pronounced peak, which means it can lead to nocturnal hypoglycemia, and then as a result of that, subsequently increased fasting blood glucose levels. So morning hyperglycemia can result. Remember that it has a less than 24-hour duration of action, and then there is interpatient and day-to-day variability, and therefore it causes unpredictable hypoglycemia, and care is required when doing insulin dose adjustments, and of course it causes more weight gain as well. Our longer acting insulins, we've got of course glargine and determa in this slide, and then in the next couple of slides we'll go through degludec because it's slightly different. Glargine, there's no defined onset of actions, but some texts suggest it's between 1 and 1.5 hours. It's generally considered a peakless insulin, and it works for 24 hours. Determa, on the other hand, tends to be around 1 to 2 hours. It has a minimal peak, so it doesn't have it's not completely peakless, but it has a minimal peak, and it's dose dependent up to 24 hours. That means depending on the dose, it will work for up to 24 hours. It's ideal as a basal insulin for type 2 and type 1 diabetes, and it ideally forms part of the basal portion of the basal bolus regimen. Glargine is the one that works for up to 24 hours, has little peak. It's more predictable than NPH insulin. It causes less hypoglycemia than NPH. It also causes less nocturnal hyperglycemia and it causes less nocturnal hypoglycemia and morning hyperglycemia, and causes less hurricane than NPH. Ditama is much more slowly absorbed and has prolonged action. It's relatively flat, but it does have a peak. It has a dose-dependent action profile. In other words, its dose will then give you its duration, most probably. It can work for up to 24 hours, and it is a good basal insulin, but we would rather prefer to use glargine. Or nowadays, some people are preferring the use of degludec, which is considered an ultra-long-acting insulin analog. Its onset of action is much slower than the other two. Its onset of action is within 2 hours, but its duration of action is roughly between 30 to 36 hours, with a maximum duration of 36 hours. It's considered a peakless insulin, much like glargine is. It causes less nocturnal hypoglycemia than NPH insulin when given at bedtime, and it only requires once daily dosing. Right, now premixed insulin are usually a combination of 30% short-acting and 70% intermediate-acting insulin. Premixed insulin is an alternative insulin regimen to the basal bolus insulin regimen, in that it is only twice a day. With basal bolus insulin regimen, you're looking at a minimum of 4 injections a day, right? Whereas with premixed insulin, it's only 2 injections per day. And roughly what you do there is you give 2/3 of the total daily dose before breakfast, or 1/3 before dinner of the premixed insulin, so that you'll have your short acting insulin, which will peak just around the time you're having your meal, and then your intermediate acting insulin will go throughout the day and will cover the midday meal as well. And then the 1/3 before dinner, your short acting insulin will cover the meal, and then the intermediate acting insulin will cover you roughly till the next day morning. The problem with this insulin regimen is that it's not generally considered very physiological or biological in nature. In South Africa, there's some suggestion that instead of doing 2/3 of the total daily dose in the morning and 1/3 before dinner, you actually go with a 50-50 split. So in other words, half of the total daily dose before breakfast and half before dinner. Biosimilar insulins. Now, remember that insulins are generally considered complex molecules, and therefore they don't have generics. They only have biosimilars. And for you to actually register your biosimilar insulin, you need to provide SAHPRA with a head-to-head comparison from the originator product. Biosimilars are intended to have the same clinical effect as the originator product, but it's produced through a different mean. So, for example, L-Glarg, right, is the biosimilar insulin to insulin glargine. You can see here, in comparison to generics, right, it doesn't even have the same molecule name, right, because the proteins on the biosimilar insulin are different. As a result of that, right, you actually have to prove that it's non-inferior. And the element 2 study that was used proved that L-Glarg was non-inferior to insulin glargine for changes in HbA1c from baseline. As a result of that, you can use biosimilar insulins instead of the originator products like insulin glargine. Now, biosimilars must be registered with SAHPRA before they can be considered for use in the patient. And you want to initiate a patient on a biosimilar insulin, not swap from an insulin analog to a biosimilar insulin. And If swap is absolutely necessary, you want to do a dose for dose swap. In other words, if you were giving the person, let's say, 20 units of insulin glargine at night, you want to swap to 20 units of L-Glarg at night. Now, as I said before, glargine and ditama are generally considered glargine and degludec are generally considered peakless insulin. I'm just drawing in degludec here. It looks something a bit more like this actually. Right, that would be degludec. Then glargine, works for approximately 24 hours. Ditama generally has a very slight peak. NPH insulin has a very pronounced peak, as we spoke about before, and therefore it's not ideal for basal bolus dosing. And of course, lispro, aspart, and glulisine are generally considered peaking insulins, and regular human insulin also peaks quite high. And you know that these are short-acting insulins. These are lispro, aspart, and glulisine are short-acting insulin analogs, and of course, regular human insulin is these one are very short-acting, and then regular human insulin is short-acting. Right, now there are two basic insulin regimens. There's the basal bolus insulin regimen and the biphasic insulin regimen. The biphasic insulin regimen is essentially your premixed insulin regimen. Now it's worth noting that when we are using insulin, what we're trying to do is reach the patient's HbA1c goal. Now what is the A1c goal? Now we'll discuss this in a bit more detail later on, but in general we're looking for an A1c goal of less than 7 in some patients, and in much younger patients with much less complications we will be looking for a goal of less than 6.5 even. Now the basal bolus dosing. The basal bolus regimen is considered to be used for the majority of type 1 diabetics and for many type 2 diabetics. And the reason for this is that it is adaptable and flexible, it's user friendly, and it's mostly physiological. It looks almost, if you were to compare basal bolus dosing to the human body's normal insulin levels, you would see that it works almost in a similar kind of a way, in that you have insulin always going on in the background in a normal person, and the insulin level will only spike after a meal, right, and then go back down, and then will spike again after a meal and then go back down, and then spike again after a meal and then go back down. And that's exactly what basal bolus dosing is. The basal insulin is that insulin that is going on in the background, which looks like this here. And then your bolus insulins are there, you're given just before your meal. So there's your spike for your meal, your spike for your meal. A normal human being's insulin profile will look something like that. And essentially, if you ignore everything below this line that I drew here, you'll see that this and this looks almost similar, and therefore we consider it to be physiological. Now, you can use NPH insulin given at bedtime as the basal insulin, right? But this does not provide enough adequate insulin levels at night sometimes, or in some cases it will over provide insulin requirements at night, leading to nocturnal hypoglycemia and morning hyperglycemia as a result. Insulin glargine must be given at a consistent time of the day, which is the preferred one. The other one can be insulin ditama or insulin degludec if required. And then of course the bolus insulin is either a short-acting or a rapidly acting insulin analog. The short-acting insulin here is regular human insulin, and the rapidly acting insulin analogs include glulisine, lispro, and aspart. And they are given before each meal is taken. Ideally, remember that for glulisine, lispro, and aspart, you want to give it roughly about 20 minutes before meal, and for regular human insulin, 30 to 60 minutes before meal. And this is exactly what I was talking about. In the normal human body, this is exactly what you will see. You have insulin going on in the background, and then suddenly you'll take your meal there at 8 o'clock in the morning and you'll get your spike in your blood glucose levels. Then your insulin level goes back to normal. Then around 1 o'clock you take your next meal, your insulin level spikes again. Around 4 o'clock you decide you're going to have a little bit of a snack, so your insulin level spikes a little bit. And then of course you have a very small meal at night, so your insulin level will spike a little bit again and then go back to normal. So as you can see, a combination of insulin glargine and something like insulin glulicine as your basal bolus regimen, in other words, a rapidly acting insulin analog combined with a long-acting insulin analog, will look the most like that other one, and you'll need to then divide the insulin dose up to be 50% basal and 50% bolus. Now the green line here, as you can see there, this is all of your basal insulin cover. And you can see here where these arrows are, that's where insulin injections are given, right? Now the first three arrows that you see are obviously the bolus dosing insulins that are given. And the very last arrow that you see here, that is for the next basal dose. Now with something like insulin glargine, for example, you only need to give it once a day at night, and therefore what you'll do is you'll give it just before bedtime or at bedtime, and therefore it will carry you through the night until the next day morning. And these little bolus doses will of course prevent spikes in your glucose levels after you eat. Now, in type 1 diabetics, the average daily dosing insulin requirement for basal bolus insulin doses is roughly 0.5 to 0.6 units per kilogram. In South Africa, we mostly use 0.6 units per kilogram. Remember that 50% of this has to be basal and 50% of this has to be bolus, which means that 0.3 units per kilogram is basal and 0.3 units per kilogram is bolus. And of course, bolus doses must be separated out between every meal. As a result of that, if the person is having 3 meals per day, it will be 0.1 units of insulin per kilogram per meal. Alternatively, if they're having 2 meals per day, it will be 0.15 bolus units of insulin per kilogram per meal. The alternative to using using a basal bolus dosing of a rapidly acting insulin analog combined with a long acting insulin analog is to use a rapidly acting insulin analog with NPH insulin. It's worth noting that in order to use this, you need to then go up to 5 injections per day. The first injection in the morning will be both your rapidly acting insulin analog and your NPH insulin for the day. Remember that the duration of NPH insulin is roughly about 18 hours or so, and so therefore you'll need to give one of the injections in the morning and another one of the injections at night. Then of course you'll give your standard rapidly acting insulin analogs before your meals again. And then of course you'll need to give your NPH insulin again here at night, so that it can start working again until the morning. Now I want you to notice a period here. I'm going to show it to you here. Right? And I want you to notice how many overlaps there are. There's an overlap here. There's an overlap here. Right. Now those are significantly important, and we'll see why in a minute. Now the advantages of using this particular basal bolus dosing is that there tends to be a faster absorption of the bolus insulin. You can inject and eat, and it's flexible. You have better postprandial control, and there is a decrease in overlap and a decrease in hypoglycemia and a decrease in the need for snacking, and there's a decrease in nocturnal hypoglycemia. The decrease in bolus overlaps, however, may mean that you run out of virtual basal dosing, and you can clearly see here you ran out of virtual basal dosing here. And if you didn't take this morning amount of basal insulin and this evening amount of basal insulin of NPH, you would completely run out, which is why you have to add an extra NPH at breakfast, so it becomes 5 injections a day as opposed to 4 injections per day. An alternative basal bolus regimen that you'll find in the government sector is combining regular human insulin with NPH insulin. Now, your regular human insulin, right, are represented by these yellow peaks, and your NPH insulin is represented by the green peak, which represents your basal insulin in this scenario. Generally, this scenario may suit kids who are eating frequently because of the number of covers of, you'll notice that the bolus insulins that you use here, almost all of them overlap, so that helps. And it compensates to some extent for the NPH insulin deficiency. Remember, you can see here at around 1600 hours or so, or 16 hours after giving the insulin, you run out of complete basal insulin, and then you're only going to take basal insulin later on again, which is the next day, morning, excuse me. And of course, the disadvantages is that there's inflexible dosing, right? There's bolus overlap, right? You can have post-meal hyperinsulinemia, right? Which can be very bad because it can potentially lead to hypoglycemia. You have increased risk of post-prandial and nocturnal hypoglycemia. Remember that with overlaps, excuse me, you're going to have this problem. And of course, you may need to snack, especially at night, to prevent nocturnal hypoglycemia. Now with premixed insulins, remember that they are just 2 injections per day, right? And they are simple and easy to administer, right? And they allow for flexible dosing ratios. They allow for fixed dosing ratios, and they are completely inflexible. They are very dependent on the meal plan for control. In other words, you can't just eat anything. You have to eat specific things, and you have to count what you're eating. Take that into account. They're not physiological and will never allow a patient to play competitive sport because of the way in which the dosing happens. Right. Now, when we're calculating basal bolus doses, let's take an example so we can see how we do it. A 25-year-old type 1 diabetic patient requires basal and bolus insulin dosing. He weighs approximately 50 kilograms. His doctor wishes to prescribe insulin glargine and insulin glucine. So that insulin glargine, as we are well aware of, our insulin glargine is our long-acting insulin analog, and our insulin glucine is our rapidly acting insulin analog. And this was the first basal bolus dosing that we spoke about, the one that is probably the best and the most physiological, and the one that you'll most commonly come across in private practice. So calculate the dose required of the basal insulin and the bolus insulins per meal. Calculate the number of pens that must be dispensed to the patient. So, in the case of basal insulin, that's insulin glargine, it's 0.3 units per kilogram, which means that it's 0.3 units times 50 kilograms, which means it's 15 units. And therefore, insulin glargine must be given as 15 units daily, and that 15 units will be given once a day at night. If a pen of insulin glargine has 100 units per ml and is a 3 ml pen, how many units will be required per month, and as a result of that, how many pens will be required? So therefore, we know that we're using 15 units daily times 30 days will give us 450 units. And 450 units divided by 300 units per pen means that you will need 1.5 pens roughly. Now you can't dispense half a pen of insulin. As a result of that, you will dispense 2 pens of insulin glargine for the patient. When it comes to bolus insulin, once again, what you're going to do is 0.3 units per kilogram. So that's 0.3 units times 50 kilograms will give you 15 units. And then you'll divide 15 units by 3 if the person is having 3 meals per day. And therefore, they will need to use 5 units per meal. And therefore, if the insulin glargine comes in 100 units per ml and is a 3 ml pen, we'll therefore say that you need 15 units times 30 days is 450 units. 450 units at 300 units in a pen means that you will need to dispense you'll need to dispense 2 pens to the patient. And if you look at the previous example, it means that if there's 300 units in a pen with 450 units required, you need 1.5 pens, but you can't dispense half a pen, so you need to dispense 2 pens. Now, what are the adverse effects associated with insulin? Insulin causes hypoglycemia, it causes hypertrophy and lipoatrophy at certain sites, and lipoatrophy is primarily due to regular human insulin. It causes weight gain as an adverse effect. It's more common with regular human insulin, and with NPH insulin is less common with your insulin analogs, both your long-acting and your rapidly acting insulin analogs. Reaction sites at the site of the injection. You also get what we call insulin edema or swelling at the site of the injection, which tends to be transient and tends to go away. You can also get insulin edema in other parts of the body as well. And combining, say, something like insulin with something later on which we'll describe, which is a drug called pioglitazone, will lead to a generalized edema as well. An allergy to the preservatives in the insulin, such as protamine, parabens, methacrysol, zinc, etc., when we're talking about lenti-insulin, for example. Now, what are common insulin antagonists? So one is glucagon, which you know of, which we use to treat hypoglycemia. Another one is adrenaline. Another one is cortisol, growth hormone, thyroid hormone, and of course your sex hormones. Now, these are particularly important when we're going to look at the next particular section, right? So, rebound after a hypoglycemic event is called the Somogyi effect. The Somogyi effect, as we discussed, will be as a result of nocturnal hypoglycemia leading to morning hyperglycemia. The dawn phenomenon is commonly as a result of an increase in adrenaline and growth hormone when you wake up in the morning, and that leads to morning hyperglycemia. Stress and physical illnesses and emotional illnesses will of course all cause hyperglycemia and can retard the effect of insulin. Drugs such as glucocorticosteroids, for example, will also retard the effect of insulin. And of course, diseases that we're going to discuss later on, like acromegaly and Cushing's and thyrotoxicosis, will all affect insulin levels and will reduce it. Puberty and pregnancy will mean that there is an increase in hormone production in puberty and an increase in hormone production in pregnancy, meaning that the number of units in puberty and pregnancy may need to be increased to adjust for the fact that there will potentially be hyperglycemia. Now, the rebound effect, also sometimes called the Somogyi effect, right, leads to morning hyperglycemia. And as we discussed previously, is very common when you use NPH insulin. Right, and what happens is your bedtime sugars drop. So around 3 a.m. you will have nocturnal hypoglycemia, which then your body will react to try and raise your blood glucose levels by releasing hormones, for example, which will lead to morning hyperglycemia. The dawn phenomenon generally occurs where there is a rise in blood glucose at 4 to 8 a.m. in the morning, and that's roughly a rise in blood glucose which is not very high. It's between 0.5 and 1.5 millimoles per liter, and insulin requirements must be increased by about 50%. It's thought to be as a result of the human growth hormone surge and occurs in both type 1 and type 2 diabetes. Remember that just in the morning when you wake up, you have a slight increase in adrenaline and human growth hormone, and this is normal to try and wake you up. And it's very variable and probably only occurs in 5% of nights. Now, how do we diagnose the difference between the dawn phenomenon and the Somiji effect? We use what we call continuous glucose monitoring to do this. And what we do with continuous glucose monitoring is we attach the glucose monitor to the patient, and it looks like a little patch or a ring-like thing that actually embeds itself in their skin. And then we let them use a continuous glucose monitor for a couple of days. I think it's roughly about 7 days or so, and then we remove the continuous glucose monitor. Inside there is something that looks sort of like a very small USB stick or memory stick, and you insert that into a computer, and then you'll get the results from that, and you'll be able to tell if there was nocturnal hypoglycemia at roughly 3 a.m. We know that it is the Somiji effect or nocturnal hypoglycemia that is involved, and if of course the person tends to have a blood glucose level that rises only at roughly about 4 a.m. in the morning or 5 a.m. in the morning, and there's no hypoglycemia that precedes it, we then say that it's most probably caused by the dawn phenomenon. Right. Now, it's worth saying that there are other things that can cause fasting hyperglycemia. For example, once you've excluded the rebound effect or the Somiji effect, it may come as a result of late night snacking, insufficient therapy, obstructive sleep apnea, and therefore we require continuous glucose monitoring to check it. Now, how do we prevent fasting hyperglycemia? The patient should avoid unnecessary snacking, right? We should monitor what is their nocturnal insulin and what insulins they're using as analogs. We may in some cases need to give metformin at night in the case of a type 2 diabetic. And of course, we need to counter the dawn phenomenon, and we need to aim to get the morning fasting blood glucose levels correct first, because if we get the morning fasting blood glucose levels correct first, that will reduce the HbA1c to a much greater extent and much quicker before we then move on to postprandial hyperglycemia, which is something we've discussed in steps. Remember that we treat to a target, and ideally we want an HbA1c of less than 7 or less than 6.5 in certain patients, and this will prevent microvascular complications and maybe prevent macrovascular complications. Now, insulin comes in both vials and pens. Commonly nowadays we mostly use pens, but some people still use vials. So if you're using the vial, you need to clean the top bottle of the vial with an antiseptic swab or alcohol swab. You then need to draw into the syringe up to the number of mark that is required, right? So you draw air into the syringe up to the number of mark that is required. So if it's 10 units, 1 unit, 6 units, whatever, you draw up air till that mark, right? Then you insert the needle into the bottle and you inject the air into the bottle. Then without withdrawing the needle, right, expel any air bubbles. And then what you're going to do is you're going to draw the insulin into the syringe. Right? Remember that the level of the needle must be below the level of the liquid so that you don't withdraw any air bubbles in. And then what you do is then, again, remember that before withdrawing the needle, you're going to expel any air bubbles. You're going to ensure then that that the number of insulin units are correct. Then the skin must be cleaned, right? The skin must not be cleaned, and the reason the skin must not be cleaned is because this leads to hardening of the skin. And then of course you need to stretch the skin, so you make a fold of the skin is the best way to do this, and this will obtain a painless injection. So in a thin person it may be necessary to pinch the skin with the thumb and the forefingers of one hand, right? Insert the needle at approximately 90 degrees to the skin, right? And the needle is usually between 0.6 and 1.2 centimeters long. Inject the insulin. Now, to prevent leakage, wait 5 to 10 seconds before withdrawing the needle. And of course, then the insulin site must be rotated to prevent lipohypertrophy or insulin atrophy. Where the insulin pen itself, this is slightly different. There's a number of things you need to do, right? We need to follow the instructions step by step on how to use the pen. Now this is very important, right? Insulin pens generally all need to be kept in the fridge, except the one that is currently in use. The one that is currently in use must be kept at room temperature at approximately 25 degrees or less. So step 1 is to prepare the pen, right? Now, preparing the insulin pen means that you are going to actually remove the lid from the pen, and in the case of a cloudy insulin or any other insulin that will require mixing, what you're going to do is rub the pen between your hands so that the insulin will then remix in the cloudy what is this? This type of insulin is what we would call a suspension, so that the drug that is suspended within the insulin can remix again. So what you'll do is you'll put the actual insulin pen between your two hands and you'll roll it between your hands. Right? Now, getting the pen ready. First, what you'll do is you'll take the paper tip of the needle. Right? You'll then use the plastic cover around the needle to then screw the needle onto the pen itself. Then you'll remove the outer needle plastic cover, and then you'll remove the cover that is directly over the needle itself. Right? And remember that needles come in different sizes, and it's important for you to know which needles are used for which pens. There's going to be an accessory set of notes which I'm going to put up, which specifically talk about insulin handling, storage, and needles. Please read through that. I'm not going to go through that during this lecture. Next, you need to prime the insulin pen, right? And you prime the pen and clear any air from the needle itself. And the reason or the way in which you do this, right, is that you usually will turn the knob for about 1 to 2 insulins. In some pens, you may even have a little line which looks like 2 wavy lines, and those 2 wavy lines are there essentially for you to prime the insulin pen. So you turn the dose selector either to the 1 to 2 unit mark, or alternatively for the 2 wavy lines. You then hold the pen and press outwards with the needle pointing upwards, and you'll notice a little bit of insulin will come out of the top of the pen, and therefore you've primed the pen and it's now ready to use. Now you may have to repeat if necessary until the actual little bit of insulin is seen out of the top of the pen, right? And then the dial should automatically move back to 0 after the priming step. Right, you'll then turn the knob on the dial until the insulin dose that you need is required. You can dial backwards too if you need to. So in other words, if you go to 12 when you're meant to go to 10, you just dial backwards to 10. The pen will allow you to receive the amount of insulin that you have set. You'll then double check the dosing window to ensure you've put the correct number of dose. So here's the dosing window here. Right, now remember to rotate sites to prevent insulin hypertrophy and atrophy. So you'll choose the site of the injection. What you'll then do is that you'll curl your fingers at the upper end of the pen and hold the pen secure. You'll poise your thumb in the air and above the actual dose knob. You'll gently pinch your skin with your free hand. You'll insert the needle at 90 degrees. You'll release the pinch, and then you'll use your thumb to press down on the dose knob until it completely stops. You'll then wait approximately 5 to 10 seconds to prevent the insulin from leaking out from the spot. Right? And there may be different requirements depending on your pen, and then after that you'll withdraw the needle from your skin. You'll pull the needle straight out of the skin. It is normal to see a little bit of a small drop, and you may even see some blood or bruise. A patient may pat the site with a tissue or cotton ball, but do not massage the area. Massaging the area will increase heat. Increasing heat will increase the absorption of the insulin, and that's not a good idea. And of course, the question is, how often should you use a needle? Now, there's different schools of thought on this. Some people say you should change the needle after every use. This means that if a patient is using 2 or 3 insulin pens or 4 insulin pens every day, if they're using, say, 2 insulin pens a day and they're using 1 insulin pen 3 times a day, they're going to need 3 needles plus another insulin pen once a day. You're going to need 4 needles a day, and you're looking at 120 needles. Some medical aids will not pay for that. Sometimes even in government sector, you don't even have enough of those needles to give that many. So ideally, what most people say is use the needle till it starts to pain, because when it pains, it means the needle is no longer sharp, right? This is perhaps an archaic way of looking at it, and perhaps not necessarily the best way to look at it, but it's one of those scenarios that you need to consider, particularly in the circumstances that you are at. Next, the insulin injection sites. Remember that the abdomen is very fast, the thigh is slow, the buttocks are the slowest, and the arms are an intermediate area in terms of absorption, which is why most of the time people will tend to actually use their insulin in the abdominal area. Remember that your rapidly acting insulin analogs and such as insulin glucosine, and of course your long-acting insulin analogs like insulin glargine are not affected by the site, so they make site rotation much easier. The type of factors affecting the absorption of insulin include exercise. The more exercise you do, the more blood flow increases. The more blood flow increases, the more that you are going to have an increased absorption of insulin. Heat will of course increase blood flow, as well of course massaging a particular area, which will then mean rapid absorption of the insulin. Cold will mean decreased absorption of insulin. Increased hydration will mean a rapid absorption of insulin. Increase in smoking will be a decrease in blood flow, will be a decreased absorption of insulin. The depth of the injection may affect the absorption of insulin. Depending how deep you inject the insulin may either be rapidly absorbed or less slowly absorbed. And the volume injected will also affect how quickly or how slowly the insulin is absorbed. It's worth noting that the abdominal and the deltoid areas have the fastest rate of absorption, and the thigh and of course the gluteal area has the slowest rate of absorption. Alright, and that's essentially the insulin lecture. The next lecture that we're going to do is we're going to focus on the acute complications of diabetes. And then the next lecture after that is of course management of type 2 diabetes and all the agents involved in type 2 diabetes management. And then the next lecture after that will be microvascular complications, and the final lecture will be cardiovascular disease and diabetes. Thank you very much for your time.